welcome. My name is Romario Gale. I'm a Jamaican trained physical therapist looking to make the transition overseas. So today's video is a shared example um, of my experience. These are like, I'm aiming to share my experiences so someone out there may learn from them, because I used to like when I was working in Jamaica that I could pass on my knowledge to the younger interns and so forth. But here I'm removed from that setting, so I'm hoping to pass on to whoever discovers this video looking for advice, tips, and motivation as it relates to physical therapy. So today's case is of a patient post-operatively who has had a wedge resection of the right lower lobe. They're having pleural effusion in the right lung field, and the physical therapist approaches the bedside to give intervention. So I want to say, for the intern watching this or the young therapist that is, for example, going to national chess, and this is a condition that is done frequently at national chess, but not elsewhere as often, and you were thrown into the fire and you're wondering what to do. So first up is you want to know what you are going to do at the bedside. So in my case, what I would have done at the bedside is, one, conduct my thorough evaluation, listen to what I found, and then most times we get so bummed out by the diagnosis, yet the patient is up and about doing their own fine and dandy thing, and then you're like, okay, it doesn't match. So what I'd recommend is conducting a thorough evaluation. Don't assume based on the diagnosis. Walk up to the patient confidently, introduce yourself, and then from there, conduct your assessment. Based on your assessment now, you're going to determine your intervention. What I normally require of persons is that they would both do a great intervention at the bedside and then leave the patient with great education and self-management strategies so that the rehab continues and is ongoing. So the options that are available to us as therapists would be airway clearance techniques, breathing techniques, and exercises. There are as well as others, but in this specific situation, airway clearance technique, breathing exercises, and exercise, right? So I want you to think of it. What would be the most important intervention to do at the bedside, right? Give yourself a few seconds, think about it. And then what would be the best exercise to leave the patient with, right? So based on that, I know that most persons would say, okay, incentive spirometry, based on the fact that it's a wedge resection, you need to expand any collapsed segments. Some people will think, oh, maybe some airway clearance technique, but you have to consider the patient that is in front of you. And you have to consider the operation procedure that was done. So say this patient is day one post-op, they may be still under the anesthesia and maybe a little more reserved, in a little bit of pain, all of that. So I hope whatever you're considering, consider those, and then moving from there to mobilize the patient. It is important to mobilize the patient as early as possible. So in my case, if I was walking up to that patient, I would introduce myself. Hi, good afternoon. My name is Romario Gale. I'm a physical therapist. I'm going to assess you, your chest and lung sounds to see what is happening. How are you feeling today? Where would you rate your pain? Then from there, I would conduct my assessment and evaluation. From my assessment, let's say the patient has decreased air entry, the percussion note reflects the pleural effusion on the referral sheet. And then from there, I'm going to intervene. So my first intervention is patient education, always, because I believe that the patient is the best person to understand their condition because they're the one living with it. It doesn't make sense. I have all the knowledge while the patient is living with it and has no knowledge of what's going on. So I'd explain what he or she has done, explain and link how that is going to play out into their function. So with a wedge resection, part of their lung is removed, so they're going to be have less lung field. So they're going to find it that average activities that would have been comfortable are becoming a little more challenging breathing wise. And then from there, educate him as how to not have further complications such as lung collapse on the operated side and not have the fluid cause collapse, cause the lung to collapse. Also, I would explain to them that, for example, the fluid is going to be reabsorbed by the body, but the lung has to stay expanded while it's being reabsorbed, or else you'll have further complications. Then my next thing is to educate them on their segmental breathing, right? The reason why I'd want to do segmental breathing and not just leave an intensive spirometer with them is that they have to understand that, yes, you're taking in air, but you want air going to the affected side. So, for example, if they're doing the segmental breathing in sitting, I want them slightly lean to the left to expand the rib cage on the right and taking deeper breaths so that the air goes to that somewhat slightly expanded, more expanded side of the lung. And then from there, in sitting, same thing, left side line, deep breaths, getting the air down to that side, reducing the chance of it collapsing or the patient developing atelectasis. So first things first, patient education. Another thing that I learned later in the years of practicing is that I or some therapists were not given the prescription in the correct pattern. So for this segmental breathing, I would want him doing it 3 times per day, 10 minutes, at least 10 minutes per 10 minutes per session. And then I would want him either splitting that into 5 sitting, 5 left side line, or a whole 10 minutes in either one. But I want him doing it at least 3 times per day. And that would continue even in my absence. So say I saw him on Friday, I'd want him to continue that on the weekend, knowing that he may not be on the weekend duty list, right? Then going from there, is my intervention at the bedside. So with that, I'm going to be doing mobilization exercises, doing his heel slides, leg lifts if he can tolerate, quad over roll, all of those to see how his body is reacting to exercise and how he's coping. If he tolerates those well, then on that first day, I'll do progressing to sit to stand. That would help to get him more comfortable, going to the bathroom, ambulating small distances, and then go from there, right? So that would be my initial first bedside assessment. So key takeaways are educate the patient, give them a solid prescription of what to do when you're not there. A lot of the time, sometimes, or in my case, early on, I would like to be the reason where the main progress happens when I'm there. And then I would feel some type of way if the patient made progress over the weekend and I came back and it was like, okay, I no longer need you, or there was no physical therapy related problem to treat. I'd feel like, oh. But then later on, I understood that if the intervention is great, then you can not have to see the patient as often and the load can be distributed, and then you can get to see other new patients that definitely need that first day intervention, right? If you notice, I did not put any airway clearance technique in the intervention. That is because based on how well the surgery was done and how early it is, they may not have any secretions, and the findings may not show any. So it wouldn't be so much on airway on airway clearance that early, but it's something to factor in. But pleural effusion is not in the airway, so it's not necessarily going to be improved by airway clearance technique. The patient may have secretions from surgery, but that is normally cleared once the patient has an effective cough. And it's not just enough to just leave a incentive spirometry with the patient and be like, do this 10 times. That is not enough of an intervention to create meaningful impact. Right, and as I'd like to say from this series is, do your best. You may think someone else may be better suited to treat this patient, but this is your learning situation, and you want to do your best and learn as fast as you can. And once you give your best, you'll only improve and you'll only get better in treating your treatment interventions and treating your patients. Thank you for tuning in. Right, and as I'd like to say from this series is, do your best. You may think someone else may be better suited to treat this patient, but this is your learning situation, and you want to do your best and learn as fast as you can. And once you give your best, you'll only improve and you'll only get better in treating your treatment interventions and treating your patients. Thank you for tuning in.